Well, hello everyone. My name is Eoin Flanagan. I'm a neurologist at the Mayo Clinic in Rochester, Minnesota. And today I'm going to talk about the CNS demyelinating diseases and some of our pediatric laboratory profiles. These are my disclosures here. I'm involved with some clinical trials for MOG antibody disease and have been done advisory boards for some of the companies that are involved with treatments for MOG antibody disease and NMOSD. So when we think about inflammatory demyelinating diseases of the central nervous system, I think sometimes the terminology can be a little bit confusing. So it's important to recognize the different attack types and syndromes and discriminate those from the different diseases. So in terms of attack types, one that I think about is acute disseminated encephalomyelitis, meaning inflammation within the brain and the spinal cord, and disseminated, meaning multiple locations. So that's one particular syndrome. Another is transverse myelitis, which is inflammation within the spinal cord, particularly the cross section of the spinal cord. Another is optic neuritis with inflammation of the optic nerve. And then we have some others. We have encephalitis, just inflammation in the brain. We have brainstem syndromes, cerebellar syndromes, and we can have combinations. Sometimes when transverse myelitis and optic neuritis are combined, we call it neuromyelitis optica or neuromyelitis optica spectrum disorder. So there are some of the attack types and syndromes that we know of, but I think we can now say that there's three major distinct diseases of the central nervous system that are demyelinating. And the first is multiple sclerosis, which ranges anywhere from asymptomatic multiple sclerosis that we used to call radiologically isolated syndrome, all the way to secondary progressive multiple sclerosis. The second disease that was discovered is aquaporin 4 antibody positive neuromyelitis optica spectrum disorder. And this was an antibody to aquaporin 4 that we'll talk about that was discovered and really distinguished that from other demyelinating diseases. And then the third well-defined disease is myelin oligodendrocyte glycoprotein antibody associated disease, or what we term MOGAD. In terms of how we test for these antibodies, there have been many improvements in our assay methodology, and these are important in terms of how we make a diagnosis. So our gold standard now really is using what we call cell-based assays. And here we can see an example here. I'll just show on the image here. What you can see is that on the immunofluorescence testing here, when we first developed the antibody, it was first discovered at Mayo Clinic in 2004 and 5, we were able to pick up about half of all the NMO cases. So each row here represents an NMO case. And then we moved to ELISA and we were able to pick up some more. And then we moved to cell-based assay, particularly the live cell-based assay. And this gave us our optimal sensitivity and we were able to pick up much more cases. And also we were able to develop higher specificity, and particularly than the ELISA. And the ELISA antibody tends to have an increased risk of false positives, particularly at low level. So you got to be a little bit cautious with low positive ELISA results, as there is a big risk of false positives with those. While with the aquaporin 4 live cell-based assay, the FACS assay that we use, it's greater. We found it's greater than 99%. 99.9% specific. So very rare to have any false positives with these live cell-based assays that we use at Mayo Clinic. Another recent important study was looking at the difference between a fixed cell-based assay. So with the cell-based assays, what we have is we have human embryonic kidney cells that we transfect the receptor of interest. So in this case, it's going to be the aquaporin 4 or the MOG antibody, and we transfect it onto a group of cells. And then we have other cells that are non-transfected in the mix. And then we look at the binding to the cells with aquaporin 4 on the surface compared to the background binding of cells. And what we look for, we have a special cutoff there. And we can do that by keeping the cells alive, and that recapitulates real life better. Or we can fixate the cells and kill the cells and then add the antibody and look for the fixed cell-based assay. But the live cell-based assay, as I mentioned, tends to recapitulate more real life. And when you fixate the cell, you may lose some of the conformational form of the receptor of interest. And interestingly, this was a study led by Johns Hopkins that we were able to participate in and assist with. And what this study found was that the fixed cell-based assay misses 1 in 4 aquaporin 4 antibodies. So you're missing 1 in 4 cases with the aquaporin 4 antibody. And that's a big problem if you're missing 25% of patients with NMO. And some of these patients had very high titer, but they were still negative with the fixed cell-based assay. What about aquaporin 4? How can we bring testing to the developing world? Well, Sean Piddock, one of our neurologists here at Mayo Clinic, developed this innovative test where you have a blood draw card, similar to how a child has a heel prick when they're born. You would pinprick their finger and then you can place it on the card. And then in that way, you can mail that card. You don't need to centrifuge it. You don't need to have it in storage, which can often be a difficulty in the developing world. And then you just place it on the card, and then you can mail the card, keep it at room temperature, mail the card over to somewhere that can extract it, like the Mayo Clinic, and then we can extract it out and we can pick up about 85% of those aquaporin 4 antibodies. And this is the way that we could get testing into Africa, where we're suspicious that there's a high frequency of NMOSD, as it tends to be higher in those of African descent. The disease tends to be more frequent in that population, so we suspect there's many patients who are underdiagnosed there. And indeed, now that there is the availability on the WHO essential medicines list of rituximab, these patients could potentially qualify for treatment. So a novel blood spot testing for aquaporin 4 is something that we're trying to bring in to help bring testing to the developing world where they don't currently have access. So let's just think about the story of aquaporin 4 positive NMOSD, because I think it's a very nice story of how you go from defining a new disease to identifying a biomarker to bringing forward a treatment. And in 1999, Dr. Dean Wengerchuk and Brian Weinschenker reported from the Mayo Clinic on the clinical course of NMO, and they reported that these longer lesions within the spinal cord, and they also reported about potential benefit of plasma exchange. There was some reports about that around that time. Then in 2002, Dr. Claudia Lucanetti in her pathology lab at the Mayo Clinic looked at some of the biopsies and autopsies from these patients, and she found that there was antibody deposition and there was also complement deposition around the samples. And then in 2004 and 5, so this gave an idea that there might be indeed a antibody-mediated condition and a complement may be involved in the pathogenesis. And in 2004 and 5, Dr. Van der Lennen at the Mayo Clinic was able to discover the antibody to aquaporin 4 and highlighted that it was an antibody to this water channel that's present on the end feet of astrocytes. And this led to a whole lot of studies over the next 10 years looking at the lab, going back to the lab and looking at cells. If you put aquaporin 4 on the surface of the cell, and if you add the antibody, some of the cells will die, but if you add complement, all of the cells die much more quickly, suggesting that complement is important in cell killing in NMO. And there was also other studies highlighting the importance of interleukin-6 and highlighting the importance of CD19 positive plasmablasts in addition to CD20 cells. So all of these things were known to be important. In the meantime, concurrent with this, new MRI features were recognized. Dr. Piddock recognized that the aquaporin 4 was localized in circumventricular organs and that lesions tended to follow that region around the third and fourth ventricle. And this led to some new phenotypes, including the Erie-Postrema syndrome from involvement of the vomiting center in the brain. As mentioned earlier, we had some serology optimization, and we also Dr. Dean Wengerchuk led a study for international diagnostic criteria for NMOSD that was published in 2015. So really gave the disease its own identity, distinguishing it from other demyelinating conditions. And then in around 2019, 2020, and even in the few years since then, we've been able to develop proven treatments with complement inhibitors, eculizumab and ravulizumab, highly effective medications at preventing new relapses. Satralizumab targeting interleukin-6, inebilizumab targeting CD19, and rituximab targeting CD20. And these are all highly effective medications. And initially, when they first reported this, and back in 1999, there was up to a 33% mortality with this condition. So a very severe condition, and many of the other patients who did not die were severely disabled. They might have been blind or wheelchair dependent. So, but now we have a disease with all of these proven medications that can reduce disability. And if we look at that impact on disability, here we can show we have disability on the y-axis and we have time on the x-axis. And historically, what used to happen with aquaporin 4 patients is they would come into the hospital, they would maybe get steroids for their episode, they would afterwards be dragging one leg, they'd had another attack, they're using a cane, another attack, they're using a walker, another attack, they're in a wheelchair, next attack maybe is fatal for them. So a large accumulation with each attack of disability that we can see here. And then what happens if you use early plasma exchange? We think that this is quite effective. And maybe after one attack, if you use steroids and early plasma exchange, you may have less disability. Then after 3 attacks, you're dragging one leg. After 4 attacks, you're using a cane rather than a wheelchair. And then if we add in the new highly effective medications, then you have one attack, you treat it aggressively with steroids, plasma exchange, you have minimal disability, and then you can go on and live essentially a normal life. Although you may be somewhat immunosuppressed, the benefits of the treatments will far outweigh any risk. So we've really changed this rapidly disabling and potentially fatal disease within 5 years to a disease, to a near cure for this disease where we can really prevent relapses and manage the condition very well. Now, if we move on next to MOG, antibody-associated disease, or what we term MOGAD, and this is diagnostic criteria that myself and Dr. Piddock from Mayo Clinic were involved with, published in 2023. And what you'll see is that this involved a core demyelinating event with either optic neuritis, myelitis, ADEM, cerebral monofocal or polyfocal deficits, brainstem or cerebellar deficits, and cerebral cortical encephalitis with seizures. You then had to have a positive antibody test, and we'll talk about the MOG antibodies a little bit sticky. So if you have a high positive result, you don't need anything additional. But if you have a low positive result or you're positive in spinal fluid, you need to be negative for the aquaporin 4 and you need some additional supporting features. And these are outlined down here, where you might need bilateral involvement, longitudinally extensive optic nerve lesion, optic disc edema, long lesions within the spinal cord, conus involvement, H sign on axial images, and other brain features. And then finally, you need to exclude better diagnoses, including multiple sclerosis. So we can summarize those diagnostic criteria into 3 major components. One is your typical demyelinating event. The second is your positive MOG antibody. Again, if you're low positive, you might need some additional features. If you're high positive, you won't. And then exclusion of a better diagnosis, making sure that the antibody fits with the clinical syndrome. So what about MOGAD? Well, MOGAD is interesting in that about a quarter of patients will be less than 18 years at onset. And what you can find is that the attack types, one is called acute disseminated encephalomyelitis. MOG antibodies are present in about 50% of that. And then children can also have optic neuritis. And then when you get into adulthood, optic neuritis really dominates the picture of attacks, but also myelitis becomes a little bit more frequent and ADEM becomes a little bit less. We have recently reported about late onset MOGAD. So MOGAD is under-recognized in people 50 years and older, and it still accounts for approximately 25% of new cases. And up to 30% of those patients are misdiagnosed, potentially as temporal arteritis or ischemic optic neuropathy. They have a high frequency of side effects from treatments, and the outcomes can be broadly similar to young adults. So they overall have a pretty good outcome, and optic neuritis again tends to dominate the picture here. And this was recently published in neurology last year. Just to talk a little bit about the MOG antibodies, the methodology, we talked about this live cell-based assay. And then what we can do with the cell-based assay here, we have this HEC293 kidney cell with the MOG on the surface. We add the patient's serum that binds to the cell with the MOG on the surface. And then you add a secondary antibody with an immunofluorescent tag, and that gives you off a signal. And then you have your control cells with no MOG on the surface that you can compare the binding with each of these to determine if there's really binding to MOG. And you can measure this with flow cytometry, which is what we do in our lab. And then we get a certain cutoff. And then we can titer it out and we can see how strong is the positivity based on the titrations, with a higher titer has been more reliable. And similarly, you could also look under the microscope here. Here you're looking under the microscope for binding to cells, or other ways you can do is the flow cytometry. And the fixed and live cell-based assays, this was a study comparing them, led by Paddy Waters from Oxford. And what they found here was that this was one study, and then there was a second study, this led to an editorial that highlighted that live cell-based assays were the gold standard for anti-MOG testing. And then Marcus Reindl led a separate study highlighting that the low positives are a little bit more challenging when you compare them across laboratories. So if you have a low positive in one lab, you may send it to another expert lab and it may be negative. So the low positives are just challenging in general. And the MOG antibody is very specific, and we did a study at Mayo Clinic highlighting that the antibody is still a very good test. It's up to 99% specific. But if you order it in low probability situations, like you order it in every MS patient, you may get into trouble with false positives. And what we see here is that in low titer results, up to 50% of those may be false positive results. On the other hand, the high titers are extremely reliable, and pretty much 99 to 100% of patients with those high titers will have MOGAD. And we recently developed a scoring system to help us distinguish true positives from false positives. This is called the True-MOGAD score, and it tends to work very well. So you take your titers, if your titers are clear positive, if you have a relapsing optic neuritis phenotype with 3 episodes, if you're under age 18, if you have an encephalitis phenotype with ADEM or cerebral cortical encephalitis, and you have supporting features, you'll get a certain number of scores. And then on the other hand, if you have positive oligoclonal bands in spinal fluid, or a gradually progressive course, or an abrupt hyperacute presentation, then you'll lose points there. And then in follow-up, if you have disappearance of at least one T2 lesion, that is also a mark in favor of MOGAD. And what you'll see here is the area under the curve here is excellent for this analysis. And if you've greater than 1 point, you've 81% specificity. If you've greater than or equal to 2 points, 97% specificity, and greater than 4 points, you'll have 100% specificity, but lower sensitivity. So this is a scoring system that can be helpful in clinical practice for people. Just going back to the fixed versus the fixed is even more problematic in MOGAD. So the fixed cell-based assays may miss 1 in 2 MOGAD patients. So this was a study again done by Johns Hopkins, and what you'll see here is there's many MOGAD patients who are negative on the fixed cell-based assay, but positive, including high titer positive in the live cell-based assay. So just highlighting that the fixed cell-based assay may miss it and may miss 1 in 2 cases. So half of cases of MOGAD may be missed. So this is really important. So if you have a patient you're suspicious for MOGAD, they're negative on the fixed cell-based assay, you need to send a live cell-based assay. And this was validated. There was another group who wrote a letter in follow-up for this, and they highlighted again that the fixed cell-based assay missed 1 in 2 cases. You can see some examples here of negative on the fixed cell-based assay and strong positive on the live cell-based assay. So again, the fixed cell-based assay has some challenges with sensitivity. Both of them have a little bit of a challenge with the false positives, but the big difference is with the sensitivity. CSF MOG antibody testing is not something we recommend upfront right away, although there's more and more studies being done on this. And in our lab, we find about 80% of patients who are positive in serum are also positive in CSF. But the CSF is also similar to the serum. You can have low positive results in up to 1 to 2% of patients. And therefore, if you have a low positive CSF MOG antibody, you have to be a little bit more cautious. But if you have a high positive, they tend to be pretty reliable. And some patients are only positive in CSF, and that's something that varies across studies, but it might be something that can help you make the diagnosis in some patients. So if you're highly suspicious for MOG, they're negative in serum with the live cell-based assay, you might want to consider offering a CSF assay, and we do that on a research basis, and people can reach out and email me if they wish to have this done. And here's an example of a MOG antibody positive in CSF, where you see these cells with them binding to the MOG on the surface, and then in serum also, and here you see a case positive in CSF, but negative in serum. MOGAD, we're a bit behind the NMO in that we don't have any proven treatments thus far, but there are clinical trials available for relapsing MOGAD. The first one is satralizumab, which targets the IL-6 receptor blocker. And then the second one is rozanolixizumab, which blocks the FcRn, the neonatal Fc receptor, and this tends to prevent antibodies from recycling back into the system and targets them for depletion, so it's almost like a plasma exchange type treatment. Just to highlight, at Mayo Clinic, we developed the first ever MOGAD multidisciplinary clinic, where we've been able to attract patients. So we have a multidisciplinary group where patients will come to see us. They'll always see one of us in neuroimmunology, and then they'll see an ophthalmologist, often Dr. Chen or others. And then they will often see other people that they might have problems, for example, urology. They might see a cognitive expert. We'll have our radiologists involved. We'll work closely with them. We'll work closely with the neuroimmunology lab to look at the lab testing under the microscope. So it's really a holistic, multidisciplinary team. We also have our physical and medicine and rehab team that will help with cognitive issues and help with other rehab aspects if patients have spasticity or neuropathic pain or other aspects that they need management with. Just to highlight, we had the first ever, we also hosted in Rochester the first ever MOGAD patient day. This was extremely successful. We had over 200 patients in person and over 150 online. This was in collaboration with the MOG project with Julia Leffler and Jim Broutman, and was a real success story where patients told us their stories about how the disease has impacted them. And we're hopeful maybe that we'll be able to do future patient days going forward. This was again, one of the patients with MOG is a cartoonist and drew these cartoons of Dr. Sean Piddock and Dr. Chen and others, as you can see here. And again, this is all the group that were present. A really successful day, and they had a great outing afterwards also. Just to highlight some other aspects of demyelinating disease, the MSP3 profile, which is something that we offer, includes the kappa-free light chains. These have just been incorporated into the recent MS diagnostic criteria, which came out a few weeks ago. And the kappa index is probably going to be something that will be utilized. The kappa-free light chains have some benefit in that they can come back quicker. There's less subjectivity to them. And so you get more consistency across the labs, and it looks like they're basically equivalent to CSF oligoclonal bands, but easier on the laboratory to do those. So these are now allowed in the diagnostic criteria. Other changes on the updated 2025 diagnostic criteria, which are now available. Yes, the kappa-free light chain index is now incorporated, as I mentioned, and also asymptomatic MS, what used to be termed radiologically isolated syndrome, can now fulfill criteria. These patients may qualify for medications, and then there's more incorporation of other MRI signs, sophisticated MRI signs with the central vein sign and paramagnetic rim lesions also contributing to the criteria. And here's just an example of the central vein sign with the vein running through the lesion, or here on cross-section, you can see the central vein. And then the paramagnetic rim lesion lights up dark on SWI or gradient echo images, and you can see this paramagnetic rim lesion. These are less common, but when they're present, they're quite specific for multiple sclerosis. One other thing that I'd like to mention is the biomarkers. So we use serum neurofilament light chain as a marker of axonal damage, and we can measure this in spinal fluid, but we can also measure it in blood, and it's something that we can follow over time. We're still working to see what role this plays, but it can sometimes be followed over time to see, is the patient responding well to treatments, or is it a relapse? But there are some challenges. It goes up with age, it can go up with obesity, and there are other factors that can affect the levels. So something we're getting more and more experience with. Okay, so what do I want to highlight in summary? So teaching points today are that in NMO, remember that we went from a disease that was thought to be a severe variant of multiple sclerosis now to its own disease with its own diagnostic biomarker, aquaporin-4 antibodies, and now we have at least 5 highly effective proven treatments in clinical trials for this disease. We talked a little bit about the challenges of MOG antibodies and false positives and this new True-MOGAD score that we've developed. We talked about the fixed cell-based assay having sensitivity issues. You'll miss 1 in 4 in your aquaporin-4, and you'll miss 1 in 2 in your MOG antibodies if you use the fixed cell-based assay. We talked a little bit about the MOGAD clinic and having a multidisciplinary care for our patients with MOGAD. We talked about the MOGAD patient day and how that is a great way to advocate for patients. And then we talked about the kappa-free light chains being incorporated into updated diagnostic criteria, along with new imaging signs, the central vein and paramagnetic rim lesion, and under study, including neurofilament light chain and others that are available out there. So I'll stop there and thank you all for your attention.